never mind.
Dr. Olson has yeah, perfect.
Excellent.
Thank you for the invitation.
No, I appreciate your guys' time. This is it's a fun way to do this. So
yeah. So tell us what do we need to do, kind of how does this work, if you can.
Absolutely. So Dr. Olson, are you online? Maybe signing in. So he's got the slides?
Yes.
All right. So we're going to wait for Dr. Olson to get up and pull up his slides. We'll wait one more minute and I'll introduce. Basically, you know, it's a 15-minute talk, 15, 20 minutes. You guys can take turns. If you want to do the full 30, that's fine too. And then we can have a discussion afterwards.
Great. Thank you.
Sounds good.
And it's usually, we try to keep it on the shorter side of things. We don't want to, you know, anyone to get too overwhelmed. Don't want to take up too much time.
Yeah, we thought Dr. Olson to kind of present the slides, and then if there are questions, we can answer. And
exactly. Yeah, I think that's the best.
That's what we thought, but we didn't know how you had organized. But thank you again.
Yeah, no problem. How's vaccination going? You guys getting vaccinated out there?
Not yet. We haven't been told that yet, but yeah, certainly they have started, I'm sure, in patients, but we personally have not. We'll see how that goes.
Yeah, well, we started today. It's some of our frontline workers over here at Northwell got vaccinated, so it's going to be a very interesting time.
Yes. As long as they tell me that I don't need to use the mask anymore, I'll be fine with that.
I think it's going to be a little while still.
Yeah, some months away from that, I think.
Yeah, without a doubt. All right. Well, let's give Dr. Olson one more minute. I know he did sign in, but then it looks like he's disappeared. Give me one sec. Let's just make sure he's got the... I don't see any emails from him. Does anyone have his contact info? I want to shoot him a text or just let him know.
Let me see. I think I have. I saw him connect, but
yeah, me too. That's the one thing.
I have just the email. Unfortunately, I don't have.
Yeah. All right, I'm going to shoot him one more email. Make sure he's good. We'll get started in a minute, everyone. Thanks for tuning in. We're live. We're live on YouTube. We're live on Instagram. We're live on TikTok. I don't know if that's a thing. Is that a thing, Nitesh? No? Not yet. Well, not looking great. I just emailed him to make sure. You guys don't have any of the slides then, right? It's better to just wait for him.
Yeah, I have a draft. I think he had some more stuff he was adding to it. I think if he doesn't come in just a minute, I can try to pull that up.
Yeah, sure. We'll get started at 5 after then. I apologize, everyone. Welcome to Tumor Talk. We're just waiting on the lead presenter to sign in. I think some technical difficulties as we saw him here before. So sit tight and get even more excited.
I believe he sent us a draft, but he said it was not final. But I don't know. Do you have? the draft. Anybody?
Yeah, I've got the draft. So if we don't see him in the next minute, I can pull that up.
Yeah, okay, perfect. And if he is not, we can talk each of us about our portion and then go from
Exactly.
there. Yeah, perfect. I was hoping that he'll be online.
So it's about 5 after. If you guys are comfortable, we'll at least get started, and Dr. Olson can come in when he gets in. But welcome, everyone. Thanks for joining in for another edition of Tumor Talk. This is a collaborative effort between the Journal of Neuro-Oncology and Lenox Neurosurgery, where we really review recent publications in the journal. We discuss kind of the research itself, the results of the research, and then its relevance on the field of neuro-oncology. It looks like we're getting our speaker in now. Hi, Dr. Olson, how you doing?
I'm really enjoying these links. Going great.
Great.
Okay.
Well, I was just doing a brief introduction. We were waiting for you. If you want to go ahead and load up your screen. I'm super excited today to have you guys here with us. So the Journal of Neuro-Oncology recently published your guys' work on revising the glioblastoma guidelines, specifically for newly diagnosed glioblastoma. And I think this is an extremely important work. I know Jason feels the same way. And we had invited you guys today to kind of give us an overview of what you guys have published and what the big updates are. This is live on Instagram, it's live on YouTube. It'll be saved on YouTube so we can share this with our friends and colleagues and get the word out. And so without further ado, I'm going to turn it over to you if you want to go ahead and talk us through. Basically, I don't know if you wanted to talk the whole time or split it up into segments. Usually it's a pretty informal conversation, so we'll just chime in when we have questions or anything like that.
Yeah, that's fine. I have a few introductory comments, and then I'd be happy to hear questions. And I think Dr. Domino, Dr. Ziu, and possibly Velasquez and Redjaw are here too, so we can let them editorialize a little bit. At any rate, this is an update, as we said. The background on this is that there is a CNS-AANS Joint Tumor Section Guidelines Committee, and we create guidelines for various brain tumor related things. This is the update for newly diagnosed glioblastomas. The progressive glioblastoma update is currently being reviewed. We've got them for pituitary adenomas, functioning and non-functioning vestibular schwannomas, and low-grade gliomas. We also do non-evidence-based guideline review for the Joint Guidelines Review Committee. They don't really look at things that are non-evidence-based. The last and first newly diagnosed glioblastoma management guidelines were published in 2008. And according to the National Academy of Medicine, which used to be the Institute of Medicine, you're supposed to update every 5 years. So this was sorely overdue. So we got on with it. We chose about 20 authors to come together in a group of writers. You can see them here. It's mostly neurosurgeons, but we have specialists from other specialties that deal with brain tumors. We broke up our writing into 6 topics: imaging, surgery, neuropathology, radiation, chemotherapy, and emerging topics. We utilized a PRISMA technique, that is the outline and checklist, that allows you to write these in a reasonable and repeatable fashion. We looked at data from 2005 in July through October 31st, 2018. The reason we chose July 1st, 2005 is that's when the searches ended for the first version of these. We looked at 5 different databases, and we pulled out about 20,000 citations, anywhere from 217 to a little over 7,500, depending on which section, and ended up narrowing this down to a few hundred full text reviews. Ultimately ended up with 34 new questions. 8 of these produced level 1 recommendations. There were 12 level 2 recommendations and 26 level 3 recommendations. And we just followed the usual CNS methodology for that. I wanted to hit a few highlights. Really, neuropathology, radiation oncology, and chemotherapy were the ones that had new things that I think were important. Some of the other stuff was not there wasn't so much of a change. But since 2008, we had the 2016 update for the WHO classification of tumors. And so we had to add all that in here. I'm just going to go over a few of the questions and the recommendations. The first question had to do whether or not IDH testing provided any more information than standard histopathology. And of course, the answer is yes, it does. It's suggested for both classification and prognostication of glioblastomas. They also recommended that for patients older than 55, IDH3 and other mutations are quite rare, and there's no reason to test for those unusual ones if you don't find an IDH1 or IDH2 mutation. Then they kind of built a case saying, does IDH wild type status designation supersede histopathology in calling something malignant? And by itself, it does not. But it does suggest that you need to do more extensive molecular alterations. So in the second level 3 recommendation here, it's suggested that you do EGFR amplification testing for gain of 7 or loss of 10, and for TERT promoter mutations. And ultimately, if you find any one of those in a diffuse astrocytic glioma, whether or not it's got any other histologic features of glioblastoma, then it should be referred to as diffuse astrocytic glioma, IDH wild type with molecular features of GBM, WHO grade 4. I do a fair amount of practice testing for individuals that do the oral boards. And interestingly, a number of the guys that are doing this now, they're 3, 4, 5 years out, are not really familiar with this. And so we had to go into that in a little depth just so that individuals were familiar with this update. These are in what we're called the C-Impact Now papers that are published by pathologists. There are about 6 or 7 of them now. And they are the forerunners of what will be the new WHO guidelines.
Do you know if this has been promoted as well through, the neuro-oncology literature? I mean, this is, very specific, obviously, to neurosurgery, like you said. But is this becoming more common knowledge?
Yeah, it is. We're working with ASCO right now to create a newly diagnosed glioblastoma guideline with them. And these are all points of discussion there, too. So I think pretty much everybody's on the same page. The main thing is to recognize that a non-enhancing thing that we would call low-grade glioma is in fact going to act like a glioblastoma, and you shouldn't just resect and observe because it will act in a malignant nature. The other thing I want to say about the neuropathology business is that they don't really do randomized prospective trials like we do with clinical trials. So the way we grade data, it's pretty much all level 3. It's the pathologists aren't very impressed with that. They think their data is more important, but just wanted you to know, just because it's level 3 based upon our methodology doesn't mean it's not important. The next point is something you're probably familiar with, looking at midline tumors. Is it important to test for the H3K27M mutation? And does that inform you beyond standard histopathology? And the answer is yes. Those that are positive for that mutation tend to exhibit a grade 4 behavior. In the ASCO guidelines that we're writing, there's controversy as to whether or not you would just go ahead and treat them with a stoop regimen. But at least in terms of retrospective information, we know that they act more in a grade 4 manner, and it would be reasonable to treat them that way. The radiation therapists were a bunch of busy beavers. They came up with 14 different questions, and I'll go over the highlights of these. The first question is radiation therapy useful in newly diagnosed glioblastoma? That's old news. We've known that since the late 60s and early 70s. And we also know with level 1 data that the most useful treatment regimen is 60 gray and 2 gray fractions. Their third question had to do with tailoring the target. And there is level 3 data suggesting that you should treat to 1 to 2 centimeters beyond the the enhancing margin. The other thing that's kind of interesting, I didn't know this, is that during the treatment, you should re-image and possibly recalculate your dose margin because the tumor defect will change over time. In their fourth question, they brought up something that was more of interest to us a few years ago, but concern over radiating the subventricular zone, even though that may not be part of the contrast enhancing tumor volume. And we were unable to find data that supported that. It was contradictory. Some were in favor, some weren't in favor, but there was nothing strong to make a recommendation about that. We were able to make a level 1 recommendation in elderly and frail patients that they should receive radiation. And if they receive radiation, that dose can be modified either with lower doses or more of an accelerated fractionation range. There's a level 2 recommendation suggesting a shorter scheme does not pull away any therapeutic value. The radiation oncologist also got into details as to exactly what that dose would be and what it should be and what the fraction number should be. I won't get into that argument here. They're better at talking about that than me. We talked a little bit about, is there any advantage to delaying radiation therapy? And the answer is we don't have an exact answer, but in general, your therapeutic benefit is good if you start within 6 weeks. We talked about IMRT. I asked a question whether or not image modulated radiation therapy is better than standard radiation therapy, and there actually isn't evidence for that. I know the radiation oncologists like to do that. It may be partly a billing issue, but we were unable to support that based upon the methodology that we use. We asked whether or not radiosensitizers were useful, and there may be some investigational ones that are, but idoxuridine is not recommended. We asked if ultrafractionated radiation therapy is useful, and we were unable to find data that supported that. The last questions deal with patients that are either having poor prognosis because of a low performance status or if they're elderly. And in a word, it is useful, but is recommended that the number of fractions be limited and the dose be limited maybe to 45 or 48 gray. For those that are fans of stereotactic radiosurgery, there is actually level 1 evidence to suggest that boosting doses of stereotactic radiosurgery to standard radiation is not beneficial. In fact, it's detrimental. So sorry to say that. There are certainly selected cases where that may be useful, but in standard cases, it is not useful to boost with that. The last slide I've got has to do with chemotherapy. When these were published in 2008, temozolomide was still relatively new. And so we have added a level 1 recommendation that concurrent and post-radiation temozolomide be utilized. Next was asked a question whether or not it's useful in elderly patients, and yes, it is, at least after radiation and maybe during it. We addressed the issue of BCNU biodegradable polymers. We were unable to find evidence that it is useful to use it in patients that are going to receive the STOOP regimen, that is concurrent and adjuvant radiation therapy and temozolomide. There's good randomized controlled studies of gliadel wafers in recurrence and with newly diagnosed patients, but it's all before the STOOP regimen. And so we were unable to make a specific recommendation. And I think you're all familiar with using bevacizumab up front. There's level 1 data in 2 different large studies that show that bevacizumab up front is not recommended, in fact, is toxic. However, patients could still be entered in clinical trials if this is being studied in a useful fashion. I know I went over that very quickly, but if you have any questions or anything, I'd be happy to answer, and my colleagues would too.
I think, obviously fantastic work, exhaustive work. I'm not sure how long something like this takes you to do, but, I know there's more than a 5-year break in between, so maybe it took the whole time.
No, I think we were active with it for about 18 months. There was a start sort of before this team did the work, but there turned out to be some conflicts of interest and so on. And rather than run into any of those troubles, we sort of took on a new team to address that. And so that's why there was a longer delay. It's
a great result. I mean, what stands out to you? I mean, obviously you highlighted some of the big things here. Like you said, there's not too much different. I think, Avastin for not newly diagnosed glioblastoma is something that everyone kind of understood, but I guess the jury's still out for recurrent. Is that something that really surprised you, or do you think you'll be surprised by what you find in using Avastin for the recurrence?
Yeah, the recurrent guidelines are written and with the reviewers now, and it is a level 2 recommendation that it which we sort of knew.
Yeah. I think the things that hit me are exactly what you pointed out, the pathology findings, that we should be treating some of these lower grade lesions as glioblastomas based on their molecular phenotype. I think that's definitely novel. And then I think good evidence. The reimaging during radiation also stands out to me. I'm not sure if it stood out to you guys as well. I'm not sure that's common practice everywhere.
Right. Matteo, can you comment on that?
Yeah, no, that is not a common practice to re-image, and some radiation oncologists are a little bit not convinced that that is an appropriate recommendation, but there was a very good paper that they studied with a different type of CTs in between the radiation, a few weeks. As you can imagine, there are 6 weeks of radiation, right?
Yeah.
And certainly the edema of the brain, et cetera, kind of things change. So that's why that paper was very good, that measured how the size or the volume of the tumor changed, and they were concerned that we were given the same kind of volume of radiation to a field that is a little bit larger than it needs to be. So that's why, yeah, it stood out to me as well. I had to read that paper several times to make sure that it was a correct recommendation.
Well, one thing we didn't touch on here today is I'm a little bit curious about is I saw that 5-ALA did have a treatment recommendation that its use was approved. Can you expand on that a little bit for surgical resection?
Yeah. Joe, you want to talk about that for a second?
Yeah, sure. I think, in looking at the surgery section, extent of resection being important is something that's well established. And I think what we then look at is, what helps you get there. The trial using 5-ALA that led to its approval did have some, grade 3 WHO tumors in it. So from a outcomes perspective, within the confines of what's allowable in the evidence for it, that we couldn't use that paper in particular. However, looking at IMRI adjuncts and 5-ALA as ways to increase extent of resection is something that's of value. Hence the recommendation or the suggestion to consider these adjuncts. I think the end result of extent of resection is what's most important. But these things, in order to get there, can be considered and so it should be looked at if consistently we're not hitting that very high extent of resection.
Yeah,
I think Joe's comments are correct. One thing you'll see is it's a level 3 recommendation, and you'd think that 5-ALA would be more important than that. But if you look at Stumor's studies, he looked at malignant gliomas, and it wasn't purely glioblastoma. And our criteria are awfully strict. And if you can't separate out glioblastoma data from other tumor types in a manuscript, the quality of the data goes way down. So
yeah, absolutely.
That's why this looks a little bit poor, but we definitely thought it should be written in.
Yeah. So where do you guys see the update in the next 5 years? What's up and coming that needs to be fully evaluated, right now that you guys can see making this list?
Yeah. Matteo, do you have any comments on what we can do to improve radiation therapy?
Yeah, so I'm sure, and we see a lot of patients on everyday practice. The first question that comes to their mind is proton therapy. As we know right now, there is no data on the proton therapy on the glioblastomas. So as the proton therapy becomes a little bit more widely used, it will be as well. I am waiting for new retrospective, but as well, I believe there is a trial going on the newly diagnosed glioblastomas to be treated with a proton. And that will be some new data that will give us some more information on that. So this is one of the things. The second thing, we have heard some new type of brachytherapy. I don't know, kind of there are sheets with cesium that are placed in the surgical cavity. That is kind of a new therapy that is coming now. And there are some new trials going around regarding that type of treatment. So I think on the radiation therapy, these will be the two main kind of drivers of our new updates. I hope we'll see some new data on that and give some new recommendations.
Absolutely. And Joseph, what do you think about things like supratotal resection? You know, there's a lot of buzz around that, obviously, right now, lobectomies.
Yeah, I think the biggest challenge that I saw when going through these is the consistent definition. So to really evaluate the literature in a repeatable way, you need consistent definitions of what constitutes a supramaximal resection. Are you going 1 centimeter beyond contrast enhancement? Are you going after all the flare? Are you doing a lobectomy if it's in a frontal or temporal location? And I think once you start breaking down those specific things, then you get very small numbers in each of those categories. That makes it difficult to make a strong recommendation there. So I think some sort of consistency in talking about the space beyond contrast enhancement, or dividing that into frontal lobectomies, temporal lobectomies, will be really where value is in terms of making recommendations the next time around. And it'll be interesting to see where that goes.
Yeah, absolutely. We have a great question actually from the audience. Could you comment on the value of experience versus recommended guidelines when you're planning treatments for these patients?
The end of each guideline document, if you get a hold and look at it, states that experience and particular patient situation trumps guidelines every time. And
yeah.
We want to make that very clear that these are guidelines, and they're not, they're not, we necessarily say options, I'd say, but they're not mandates. And it is important to recognize that we can't always fit a patient into all these pigeonholes. Experience has to address that.
Absolutely. But I think you guys have done a tremendous job again. And I think, Jason would reiterate that the contribution of the journal is fantastic, and happy to have you guys on board. I really appreciate your time. Like I said, we try to limit these to about 25, 30 minutes or so, just to keep people interested. The talk will be up on YouTube. You guys can share it. We'll send a link out. And once again, thank you guys. Any closing remarks before we end it?
Not from my end. Have a look at them if you have time. They're kind of long, but there is stuff in there.
Yeah, thank you for the invite.
All right, guys. Have a great night. Stay safe.
Take care.
Keep an eye out for the vaccine.
Yes, thank you.
Take care. Bye.
Bye.